All right. Hello, everyone. My name is Kathleen Thornburg, and I will be providing this lecture. We're going to start with the renal and then move our way onto the gastrointestinal system. And we will get started with this. I did provide my email here in case there are any questions from this lecture. You can always email me, and I will get back to you as soon as I can. All right, let's get started. Okay, so for our renal anatomy, and these learning objectives were provided by Jamil. So I think this is kind of where to focus on. Um, there's typically some additional context provided just so that, um, all the material makes sense. But these are, what to focus on in terms of, examination, right? So after this lesson, you as a learner should be able to do these things pretty well. And one that's identify the major structures of the renal and urinary system, list their primary functions, identify the anatomical structures of the nephron, explain the process of urine formation, explain how kidneys can alter blood pressure, pH, and electrolyte concentration, and list the most common electrolytes in their normal ranges, identify the most common electrolyte disturbances, and we'll go through each one of these. So let's just start with the renal system and what is contained within that. So we have two kidneys, two ureters, one urinary bladder, and one urethra. And the primary functions of our renal system, as we may assume, is to undergo excretion and elimination of metabolic waste. So kind of getting rid of waste via urination, right? Also homeostatic regulation. So essentially, it's going to help control our blood pressure, blood volume, electrolytes levels, right? So if you imagine our cardiovascular system is a closed system, if I pull water out of it, I'm going to lower my blood volume. And that's also going to lower my blood pressure, right? Can also control how many of the electrolytes I'm going to reabsorb or excrete. So we'll go through that a little bit more in detail. Some more functions is that the kidneys actually convert vitamin D into its active form. So if you take vitamin D supplements, it's important that our kidneys actually function to make that vitamin D active. Why is vitamin D important? Because it helps us absorb calcium that we've digested. Otherwise, it's hard to absorb that calcium, right? The other important feature is that our kidneys help control red blood cell production. Kidneys are going to secrete this hormone, erythropoietin, which stimulates blood cell production in our bone marrow. So the kidneys have a pretty vast array of functions, right? So where are the kidneys located? And we're looking posterior view. So our kidneys are going to be anterior to ribs 11 and 12, right? 11 and 12. And because we're looking from the posterior view, this is going to be the left side of their body and the right side of their body. So that right kidney is going to be slightly lower because we have the liver in the way, right? Another important thing to note is the kidneys are retroperitoneal, and that means that they're behind this peritoneum, right? So I'd have to open the abdominal cavity, move my intestines to the side, right? And then look at this posterior abdominal wall that's just covered with our parietal peritoneum, right? So if I even removed all those intestines, you'd still see this kind of membrane covering it, right? So this is just our intestines removed, right? So you see our kidneys are behind that parietal peritoneum. And so for me to truly see the kidneys, I'd have to remove all of that. And there are our two kidneys and our ureters. Right, you see our ureters here going towards our urinary bladder. Okay. The kidneys are also encased in a pretty thick capsule that is basically filled with fat. So the kidneys are surrounded by fat just to protect them. We can think of fat being kind of the protective function as well as, insulation and an energy storage. But for our kidneys, it's really, hiding back there in our retroperitoneum and kind of snugly protected by a fat layer. Okay. So let's talk about the gross external features, which means just what we can see with our visible eye. So this is our kidney, and here they've reflected this fibrous capsule. In red here, we have our renal artery, and blue is our renal vein. The renal artery is going to be typically posterior to the renal vein. A couple other things of note is that artery walls are much thicker than the veins. Veins have a lot more, have a thinner wall. And these are kind of just ways to know, what's an artery and what's a vein. So you're not relying on red and blue, as that's not typically what you're going to see in the body. Down here, we have our ureter coming out, and that's going to be transporting urine down to the urinary bladder. And then we also call this entire region where you have structures entering and exiting our hilum. So those are kind of important structures just to note about the kidney from the outside view. Once we cut into the kidney, we can see some more features. So this inner area is called our medulla, or renal medulla, okay? And the outer portion is called the renal cortex. Renal cortex is primarily where filtration is going to occur. So essentially filtration occurs here, and then it's going to be transported through these collecting ducts within these pyramids. That's going to be collected in kind of these areas here that we'll describe next. Okay. So we already talked about this renal cortex, and then the renal medulla, or this inner portion, is formed by essentially these renal pyramids. So you can think of like these kind of triangle-shaped structures as a renal pyramid. And essentially, at the taper, they're called renal papilla. Papilla just means mountain, right? So it's kind of like this little tapered point at the end of the renal pyramid, right? And then in between these pyramids, right, or renal pyramids, we're going to have these renal columns, okay? So those are the structures in between, and that's where we're going to see a lot of our vasculature, okay? So essentially, we're going to have filtration occur at the cortex primarily. And then we're going to, let's just go back one, have that filtrate collected through collecting ducts. If you see how it's kind of striated here in this medulla, right? Or sorry, medullary pyramid, that filtrate is going to collect at the tip of that papilla and then fill in these areas, right? You can think of it kind of like as a little coffee filter, or like when you're collecting coffee, it's like just kind of dripping into these areas. So from those medullary papilla here, urine's going to collect in these first structures called our minor calyces. So at the tip of each papilla is one minor calyces or calyx, and then several or more than one minor calyx is going to form a major calyx. Now these major calyces are going to form our renal pelvis, and essentially the ureter is a continuation of the renal pelvis. It's just exiting, and urine's going to flow down into our bladder from there. This is just a colorized X-ray image in which they injected dye, basically into where they gave them intravenous dye, and then that was filtered through their urine so that we can pick up on these structures. So it's pretty amazing. You can see kind of the shape of the kidneys here, those minor calyces, major calyces, and our renal pelvis. And then we have our ureters coming down to join the bladder. Okay, so let's talk a little bit more about our ureters. So each ureter is going to have 3 layers. Essentially, we have this mucus coat, and that just means that it's in contact with the lumen. So the lumen's kind of the hole in the middle. If you had a tube of toilet paper, the lumen is the hole in the middle of the tube, right? And that first layer that's going to be in contact with the contents of the lumen, aka the urine, is going to be that mucus layer, right? Or mucosa. That specific mucosa is called transitional epithelium, um, just meaning that it can kind of expand when there is urine inside, right? The next layer is a muscular layer, right? So we have an inner longitudinal and an outer circular layer that's going to help move urine down the ureter. Okay. And then lastly, we have a fibrous layer outside called our adventitia. So the key takeaway from this is that essentially there's a specialized layer in contact with the urine itself, surrounded by muscular, surrounded by a fibrous layer to kind of protect the ureter, right? So essentially, this muscular layer is going to be contracting to propel urine along the length of it, which is really important because if you don't have the ability to propel urine, then what would happen if you were laying in bed and you didn't have gravity to help you, um, you know, um, carry urine down to the bladder? Now, once we join the bladder, so if you notice, the ureters are up here, and then they're going to kind of plug into the bladder, and you have these openings or orifices. Now, these are specialized. They have a little flap-like fold that essentially kind of help the urine flow in a one-way direction and prevent backwards or retrograde flow of urine. Okay. So the bladder itself is a hollow muscular organ that's there to both store urine and then contract to push urine into the urethra. Again, we always want to flow down into the urethra and out of the body. We don't want urine to flow back into the ureter, right? So if you notice that on this body, it's kind of a hemisected view. I'm looking laterally. Um, and here's the pubic bone right here. So the bladder is right behind the pubic bone. And you can see the ureter coming from above. If you see this tube coming from below and you get confused, you think that's the ureter, that is our vas deferens. It's coming from the testy here, or that epididymis on top of the testy. So if you see a tube that's coming from outside of the pelvis to the back of the bladder, that's the vas deferens. The ureter is always coming from above where the kidneys are. So what's important to note is that we have that transitional epithelium in the bladder as well. That essentially they are kind of like fat square-shaped cells that flatten when the bladder is full. And it also has a lot of little folds in the bladder as well. You can kind of see this pitting here. The point of that is to allow expansion of the bladder. So when the bladder is empty, you're going to see a lot more folds. And then when the bladder is full, the walls are going to appear more smooth. So bladder has multiple layers as well, but we're going to have 4 layers here. We have our mucus coat, or again, that mucosa. And it's still that transitional epithelium that can go from cuboidal to a squamous shape as it can flatten out when it's full. And you can see these pretty large folds here. And that allows us to have the space for the bladder to expand. We have an additional layer just underneath that mucosal layer called the lamina layer, or lamina propria, also known as that submucosal layer right here. And then deep to that, we have our smooth muscle again. And so that's our muscular layer to help the bladder, allow the bladder to contract. And we have our serous layer on the outermost portion of that. So whenever you see smooth muscle, you should think that that is an involuntary muscle, that it's not something that we consciously control. Thank goodness, we don't have to think about contracting our bladder. That's one less thing to have to worry about, right? So a little bit more about the smooth muscle layer. These muscle layers are interlaced, and we call that collectively the detrusor muscle. Detrusor muscle is going to be innervated by our parasympathetic nerve fibers. Parasympathetic nervous system is that's our rest and digest nervous system. The other system is that sympathetic nervous system. Sympathetic nervous system is our fight or flight, and that's actually going to shut down, digestion and urination. Our parasympathetic is what's going to allow our bladder to contract for urination, aka micturition. So that's where we're on next. So micturition is the process of expelling urine from the bladder. So essentially, our parasympathetic nerve fibers are going to send an impulse to that detrusor muscle, which will cause it to rhythmically contract. We'll also have some contractions of our abdominal wall and our pelvic floor muscles, as well as these sphincter muscles. So this is our first time introducing a sphincter, which is just a round or circular muscle that's typically kind of surrounding a tube shape. And sphincters will typically contract to pinch off or relax to open that tube to allow the contents to pass. So this internal urethral sphincter is right after the bladder, or kind of like at the junction between the bladder and the urethra. It's an involuntary muscle, as in we don't control that. Our parasympathetic nervous system is going to relax that muscle and allow for urination. We also have an external urethral sphincter, and this is a voluntary muscle. So we learn how to control and squeeze that muscle when we don't want to urinate. So when you have the urge to urinate, and you're not in the proper position to urinate, you might control, or you're kind of forcing that muscle closed, right? So that's our external urethral sphincter. So for urination to happen, basically we would have to relax both of these to allow urine to flow. Unless you have an overwhelming amount of urine in your bladder that might override our external urethral sphincter as well. So moving on to the urethra, this is going to be basically the pathway of urine from our bladder to outside of the body. It's essentially a tube, and it's lined with our mucous membrane. It also has smooth muscle tissue. It's going to help push urine out of the body. And there's also mucus glands that are going to secrete mucus into that the urethral canal. So for anatomic males, we essentially divide the urethra into three main parts. So this is our bladder again, and your ureter. So the first part is called the prostatic urethra, and that's because it's running literally through the prostate. Second part is the membranous urethra, and this is actually surrounded by that external urethral sphincter. So this is where contraction occurs to prevent unwanted urination. And the last part is a spongy urethra, which basically is traveling through the penis, and specifically through the corpus spongiosum. So if you see this erectile tissue in kind of where I'm outlining here, the urethra essentially goes straight through that erectile tissue and exits at this external urethral orifice or opening. Okay. And that's a review of where our internal urethral sphincter and external urethral sphincters are. Okay. So for anatomical females, this is our bladder here. So we've just kind of hemisected it open as well, so we can see inside the lumen of the bladder, right? It's still going to be behind our pubic symphysis, and it's underneath our parietal peritoneum, just like in anatomical males, right? So this is our parietal peritoneum covering the bladder as well. Okay, so our urethra for anatomical females, we don't just break it into three parts. We just call the urethra this structure here, just exiting from the bladder. And essentially, this muscle here is where our external urethral sphincter is going to be. And our internal urethral sphincter is going to be just at the junction between the bladder and the urethra. Okay. Same as before, where the internal urethral sphincter is involuntary, external is voluntary. And this is something that you learn, as in babies don't really know how to control their external urethral sphincter. And so they have to wear a diaper. And then as we get older, we lose control of potentially that muscle. So the urethra is going to end or exit at the external urethral opening or orifice between the clitoris and the opening of the vagina. So I'll show you from another view. So a view from below, this is the opening of the vagina. This is the external urethral orifice, and the clitoris is more anterior here. Okay. So I'm going to do just a little bit of a checkpoint. So this is a way you can kind of check your knowledge and make this lecture a little more interactive. So feel free to answer this question yourself at home if you'd like, and I'll share the answer right after. Okay, question. What is true about the muscular structure indicated to the right? A, it's a muscle under voluntary control. B, it is surrounding the penile urethra. C, it has flaps preventing backflow from the bladder. Or D, it is made of smooth muscle. I'll give you a second to think about that. All right, so the answer is A, it is under voluntary control. So this is our external urethral sphincter. Our internal is right at the border between the bladder and the urethra. It is not surrounding the penile urethra, it's surrounding the membranous urethra in this case, because there's a prostate. It is in what's preventing backflow and has flaps are these urethral orifice, or sorry, the orifice of the ureter. And then it would be made of skeletal muscle because that's voluntary. Smooth muscle is our involuntary muscle. Okay, moving on. Blood flow to our kidneys. So essentially, this is our aorta here, and this is our left and right kidney. And as I showed at the beginning of class, this is our inferior vena cava. The renal vein tends to be more anterior, and the artery is kind of behind it, right? The renal arteries are going to both become filtered by the kidney and then also provide the oxygen and nourishment to the tissue of the kidney itself. It's kind of a 2-for-1, which is nice. So then after the kidney has, filtered the blood and used up the oxygen from that blood, it's going to send filtered, deoxygenated blood to the inferior vena cava through these renal veins. Okay, so that's our oxygenated blood going to the kidney, becoming filtered, and then deoxygenated blood returning from the kidney to the inferior vena cava. As the renal artery approaches the kidney, it's going to essentially divide into smaller and smaller and smaller arteries and then arterioles until it makes its way towards the cortex. And remember, the cortex is where filtration occurs, right? So let's talk about each one of these branches. We have the aorta. Aorta is going to branch off and give our renal artery. Renal artery is going to branch into segments. So that's our segmental artery. So each one of these is a segmental artery. Then those arteries go between lobes, right? So we call those interlobar, going between lobes of the kidney, right? Now let's zoom in. This is one of our renal pyramids, right? This was that interlobar, okay? And then we will have our arcuate. You can think of kind of like arching as for arcuate, okay? And then cortical radiate arteries. So this is the cortex. So the arteries going straight through and radiating through the cortex are called cortical radiates. So sometimes with anatomy, the names kind of help us out. From there, we're going to have to zoom in on one of these tiny structures here, right? Essentially, we had our cortical radiate going, like, kind of piercing through that cortex. And then we see these like little balls out here, and we zoomed in. So essentially, those cortical radiate arteries are going to give off an afferent arteriole. Afferent means kind of entering in or like going in. And then our efferent, oh, and our afferent arteriole is going to feed into this capillary network called the glomerulus. And we'll talk a lot about that. And then from our glomerulus, it'll exit as our efferent arteriole. I've changed colors because we started using up some of that oxygen, and now it's kind of a mixed oxygenated blood. Okay, efferent arteriole is going to essentially send a bunch of like a bed of capillaries around what we call this tubule system, right? And so we call those peritubular capillaries. Essentially capillaries going around our tubular system. So peritubular capillaries. And then we're going back to this picture so you can see where our vasa recta are. Recta means straight. Vasa means like blood vessel. So essentially these kind of blood vessels going straight up and down in our renal pyramids. Okay. So that vasa recta is going to feed into that from that efferent arteriole. It's going to feed into our cortical radiate veins, right? So essentially from there, that oxygenated blood is deoxygenated, and it's just trying to return from the kidney. Okay. So vasa recta kind of dump some of that blood into cortical radiate veins. Our peritubular capillaries also send blood to our cortical radiate veins. From there, we're traveling back into our arcuate veins, interlobar veins, and then you can probably guess that these are segmental, right? So we called that our interlobar veins, our segmental veins. And then coming back to our renal, our renal veins to our inferior vena cava, which is going to return deoxygenated but filtered blood to our heart. Okay. So let's do a checkpoint. What blood vessel is bringing blood directly into the glomerulus? So is that our efferent arteriole, our afferent arteriole, our interlobar, or our segmental artery? Okay. So it's our afferent arteriole. Efferent comes off here, and interlobar and segmental are way off in between our renal medullas, our renal pyramids. Okay, so now let's talk about how we actually produce urine. So we talked a little bit about blood flow from our afferent arteriole becoming the glomerulus, exiting as efferent. So essentially, filtration of blood is going to take place at the glomerulus. If you are like me and for as a kid or for a long time, you think that essentially urine is filtered from the digestive system or something like that. Yeah, it's actually not. I thought that for a long time, but essentially our kidneys are producing urine by filtering our blood. So our blood plasma actually is filtered through the system around 60 times a day, which is pretty incredible. So we produce about 180 liters of filtrate per day, right? So filtrate is just the fluid that kind of collects in this capsule from our plasma. And we end up collecting or reabsorbing about 99% of that filtrate back into our blood. So therefore, despite us filtering 180 liters uh, of filtrate per day or 120 milliliters of filtrate per minute, we only end up urinating about 1.5 to 2 liters per day. So if you can imagine that the process of reabsorbing that fluid is so important, it'd be pretty critical that we can reabsorb 99% of that water. Otherwise, we're going to be incredibly dehydrated, or our blood fluid volume would just crash. So if you can imagine, the ability to retrieve water and electrolytes, which we'll share later, is really important. Okay, as we shared before about this afferent arteriole, blood is going to flow into our afferent arteriole, into a network of capillaries called the glomerulus. So this glomerulus is essentially a ball of capillaries that we consider leaky or fenestrated. So it doesn't have quite the tight junctions we see in capillaries in the rest of our body. It has kind of more of a leaky structure. Blood is going to continue and then exit out of the efferent arteriole. But essentially, fluid's going to be pushed through that capillary system and collected here in this capsule. Capsule is called Bowman's capsule, right? That's surrounding the glomerulus. And then the fluid is going to exit through what we call the proximal convoluted tubule. So if you imagine, blood is coming through, it's going through this pretty leaky system, and then blood is going to exit. And meanwhile, some of that fluid is going to be collected here in that capsule and then exit. Now you may wonder, is this blood going to be just red blood cells, like dry blood? Well, no, only about 20% of the fluid from our plasma collects here. The rest of the 80% of the fluid in blood is going to exit. Okay, so if you think more of it as like a water slide that they kind of poked a bunch of holes through, someone's going through the water slide on a little like floaty, kind of goes through all the way and then exits. And meanwhile, some of that water kind of makes it through the holes in the water slide and fills, this capsule here. Little animation just to kind of demonstrate that. So, just wanted to share what are the membranes that form this kind of barrier between the glomerulus and Bowman's capsule. So essentially, we have our capillary endothelium. So we zoom in here. Let's show you kind of a bigger picture. Capillary lumen, so that's where blood is going to be. And endothelium is just like cells that form a blood vessel. So this is just our capillary endothelium, just cells that form like a normal capillary. But in this case, we have fenestrae, aka openings kind of between these blood vessels, or sorry, these cells that form the wall of the blood vessel. Then we have a layer called the basement membrane, and it's kind of a gel-like matrix that's negatively charged, and that's going to help prevent essentially large proteins that are negatively charged from going through. We want to keep those in our blood plasma. And then we have our podocytes here. And these are essentially like another layer kind of resting on top of this basement membrane to essentially control the filtrate that's kind of coming through. So one thing that kind of helps me understand is that if you think of the glomerulus as this ball, and then these capillaries are kind of pushing into the ball, they're acquiring this layer. So in the layer of the podocytes essentially comes from the Bowman's capsule. It's kind of creating this this extra protective layer on top of the capillary. So if you think of like if you had a ball and then you push your finger into it, the part of the ball that's surrounding your finger is going to be the podocytes. That's kind of, the contribution from Bowman's capsule here. And the point is that it's just when we're filtering our plasma, we want to have control of what is filtered out of the plasma and what stays in our blood plasma. So if we have damage to our basement membrane here, we can have an issue called glomerular nephritis. And then because that layer is basically damaged, then we can start to see these blood plasma proteins entering our filtrate, such as albumin, and that's not a normal feature defined, right? If you also found blood cells kind of in the urine, that would also be a feature or something that would be not considered normal, right? So this is just a couple histological images I thought would be great to share. This is some glomeruli. You can see those are our cortical radiating arteries, little afferent arterioles entering, and then there should be an efferent arteriole exiting as well. Essentially, they like add a plastic injection into the blood vessels so that they can capture this image. This is an up-close image of some podocytes that are kind of helping create that additional barrier on top of the capillaries. Okay, so what's kind of the point of all this? What matters is controlling what passes through as filtrate, water, nitrogen, or nitrogenous waste, and nutrients. So think, very small structures, small molecules in water. And then what doesn't pass through? Blood cells, albumins, and platelets. Those should all stay in our blood as it passes back through the efferent arteriole. So we don't want those to pass through. So again, if we find albumins in our urine, if we find blood cells in our urine, that can be a sign of a damaged kidney, right? But you might say, well, if I find blood cells in my urine, couldn't that just be something damaging the urethra and causing that to bleed? Yeah, it actually presents differently. So blood cells that come from a damaged nephron or the damaged glomerulus will typically clump together and form what we call like a cast. And so, when they're evaluating blood in the urine, they'll look for if that blood is kind of clumping together as a cast versus typical blood cells. And that kind of gives them a hint if it's the glomerulus that's damaged or if it's just, the urethra or ureters or somewhere else in the renal system that's bleeding. So how do we determine our glomerular filtration rate? So first off, glomerular filtration rate is just the rate that blood is filtered through the glomeruli. Okay, so let's zoom in again, right? Essentially, these two forces oppose each other. So hydrostatic is essentially the force of blood entering the glomerulus. So if you think of blood, the more forceful it is, it's going to push more of that fluid from the blood into Bowman's space to be collected. Now, there's an opposing force that's called our osmotic force. And so if we think back to those albumins, which are large negatively charged proteins that cannot cross through our glomerulus, right? So those albumins are going to be essentially staying within that capillary lumen or staying on the side of blood. Because those proteins are there, they're essentially creating an osmotic force, as in a force of water wanting to come back into that capillary lumen. The reason is that with osmosis, water is going to want to flow from an area of high concentration of water to an area of low concentration of water. So if we have more stuff dissolved in the blood here, then essentially we have a lower concentration of water molecules than we do out here. So this force of osmotic pressure is essentially creating a force that wants to pull water back into our blood. Okay, so the difference between the two of these is going to influence our rate of glomerular filtration. So when we initially filter our blood plasma, in that first set of or that fluid that initially comes out and is collected in Bowman's capsule and then exits proximal convoluted tubule, that first uh, filter or filtrate is called ultrafiltrate because it hasn't had the chance for us to modify it at all. So it will have all, nutrients, wastes, and water in it that we want to kind of modify later. So initially, the fluid that collects there is called ultrafiltrate, but then ultrafiltrate is going to become filtrate that's concentrated into urine. So fluid from that proximal convoluted tubule is going to work its way through our tubular network. It's going to become more concentrated as we pull water back into our bloodstream. And we absorb more salts, aka the electrolytes that we want. We absorb any essentially the nutrients that we want, and we leave in the waste that we want to urinate out. And so where does that water go that we've reabsorbed it? Well, remember that peritubular capillary system surrounding essentially our tubules. The tubule system is gonna work to pump water out of that filtrate. And what kind of like once ultrafiltrate leaves the Bowman's capsule, and now it's just called filtrate. But essentially, our tubular system is going to work hard to pull 99% of that water back into our bloodstream, and then the salts that we want and all the nutrients, right? Then fluid from that tubule system is going to be collected in our collecting ducts. Remember, that's that kind of striations down our renal pyramids, right? And that's where our final concentration adjustments are made, right? So if you notice when you're really, really dehydrated, you have that dark urine versus when you're hydrated and it's kind of clear. It's because our kidneys are able to adjust how much of that, how much fluid we're pulling back in to our bloodstream, right? But all in all, we still collect about 99% of that original ultrafiltrate back into our bloodstream. So that 1% is kind of what makes the difference between how concentrated your urine is or not. Let's talk about the nephron. So essentially, the nephron is the functional unit of the kidney. And when we say functional unit, essentially we mean like where the work is taking place. So where filtration actually takes place and urine is formed is based on the nephron, right? So our renal corpuscle, these are just kind of definitions. Our renal corpuscle is our glomerulus plus the associated Bowman's capsule. And then our nephron is a renal corpuscle plus the tubular network, right? So that's kind of our functional unit. So one of these is one functional unit of the kidney, but incredibly, we have about 1 million functional units per kidney. So if you have 2 kidneys, you have about 2 million nephrons working hard every day. Pretty impressive. So let's talk about, actually forming urine and, kind of what we want to keep, what we want to get rid of that filtrate. Okay, so when we talk about tubular reabsorption, that means what is in the filtrate that we're actually just pulling back into our blood. So all of this in red here is essentially everything that our tubular system is pumping back from our filtrate into our blood. So water, about 99% of that water is reabsorbed. Salts, glucose. So essentially this first portion, that's where we're going to see glucose, or the proximal convoluted tubule. We're going to see glucose reabsorption, right? So glucose was able to make its way into our Bowman's capsule because it's a pretty small molecule, but we want to reclaim all of that glucose. So all that glucose should be reabsorbed into our bloodstream, and we should not see it in our urine unless someone has overwhelmed this system, right? So if they have so much blood or sugar in their blood, so much glucose in their blood, they overwhelm the ability to absorb, then we can see glucose in the urine as that's excreted. So water, salt, glucose, bicarbonate, so our buffering system that we'll talk about, and ions, which is kind of dissolved salts. So all of these in red, essentially, we are wanting to reclaim back into our blood. We don't want to urinate that out. These are salts, potassium, bicarbonate, water, sugar, or potassium, magnesium, calcium, right? So that's kind of what this is showing. Then, what is tubular secretion? So that essentially means from our bloodstream, right, those peritubular capillaries, our tubular system is going to pull stuff from that blood to be secreted into our filtrate. So it's kind of pulling stuff out of the blood again that we don't want to keep. So some of that is wastes, medications, and then it's kind of excess potassium, right? So excess potassium and hydrogen ions, and that's gonna play a part in controlling essentially like the pH levels of our blood as well. Okay, so in short, reabsorption is what we want to pull back into our blood from our filtrate, and secretion is what we want to take from our blood and secrete it into our filtrate. And then that determines our excretion, right? So here's a better image, reabsorption, taking stuff from filtrate, putting it back to the blood. Secretion is basically secreting more molecules, or basically what we want to get rid of from our blood into our filtrate. And the end result is excretion. So this is kind of a simple formula. Excretion is going to be our filtration, so the initial fluid, minus what we've reabsorbed into our blood, plus what we've secreted back into the filtrate. This is another way to look at it. Here's our peritubular capillaries. We're reabsorbing some, what we want to keep. We're getting rid of what we don't want to keep. And then the kind of end result is urine formation, which we will excrete via micturition. So how do we measure that glomerular filtration rate? How do we track how healthy our kidneys are? There's a couple ways. One is we basically use blood tests, and we kind of track a molecule that is pretty consistent to track to show how well our kidneys are functioning. So one test is our creatinine levels. This is a chemical waste that essentially our muscles kind of produce. It's like when our muscles are breaking down, it kind of produces creatinine. So our creatinine test is essentially testing how well our kidneys are going to filter creatinine out of the bloodstream for excretion. So you do a blood test, and then you see like if what the range of what the creatinine level is, and if it's in a normal range or not. They do alter it for men versus women for normal creatinine levels. Blood urea nitrogen test, or BUN test, or BUN. Essentially, that's instead of creatinine, you're just kind of following the urea nitrogen, which is a waste product, and you're kind of measuring the amount of that in the blood just to see how well the kidneys are working. It also kind of tells us about the liver, because essentially, um, this product is um, filtered by the kidneys, but it's essentially produced by the liver breaking down proteins. So if we have a very low BUN, that just means that maybe our liver is not functioning well to break down old proteins or break down proteins in general. Now, if we have a very high BUN, then that means that we're not able to excrete that out. Okay. So creatinine may be a better test directly of the kidney, but it's good to get both if both tests if you're concerned about kidney health. And this is just the kind of the normal range there. So based on like calculate kind of equations, you can find out what the GFR is based on those tests. And our normal is that 120 milliliters per minute of blood filtrate per minute. And then if you can see kind of what that range is for healthy versus early stage kidney disease, full-on kidney disease, and kidney failure. This is another kind of chart, and it shows that age does influence like your typical filtration rate as well. And then this just kind of shows like essentially if you're in that pretty normal range, 90 to 120, what the kidney function should be. And then kind of as we decrease our filtration rate, we're showing that we have more and more kidney function, leading to kidney failure. So what can impact glomerular filtration rate? Okay. Well, a couple things. So if we have, an increase amount of blood volume or blood pressure, we're going to increase our glomerular filtration rate. And if we have essentially a lower blood pressure, we're going to have a lower GFR as well. Of course, there's uh, other things that can influence it as well. And ultimately, it's caused by the difference in that hydrostatic versus osmotic pressures. Let's do another checkpoint. So if I increase tubular reabsorption, what will happen to the amount of filtrate excreted? So if I increase tubular reabsorption, what do we expect for the amount of filtrate we excrete? So we expect it to decrease. So if we're reabsorbing more fluid back into our blood, then we expect to urinate less of that out. Okay. So how does our renal system respond to a decrease in blood pressure, blood volume? Because remember, if our blood system is a closed system, then the amount of water we pull out from that system or we reabsorb can really affect our overall blood volume and our blood, aka our blood pressure as well. So essentially, we have this system called our renin-angiotensin-aldosterone system. And it's a pretty complicated system, but we'll go through it like step by step. This might look like a nightmare here. I used to hate pictures like this, but again, we're going through it step by step. So hopefully it all is cool in the end. So essentially, there's three primary compounds or molecules that we're going to see involved in this. We have renin, angiotensin 2, and aldosterone. There's going to be other kind of factors as well, but these are what form that system. Okay. So essentially, what is the goal of this whole system is to elevate arterial blood pressure. So it's going to also cause vasoconstriction. So constricting the blood vessels is going to cause our blood pressure to go up. And we're also going to have an increase of water reabsorption. So we're going to increase our blood volume. And also the other goal is to increase our salt reabsorption. Okay, so more the more water we reabsorb, the more our blood volume goes up. right? So let's start with renin. Okay, let's zoom in on our, essentially, this is our renal corpuscle, right? So our glomerulus with our um, Bowman's capsule. So that's kind of off screen here, but the um, glomerulus is here, and then Bowman's capsule is here. And then what we also see is our afferent arteriole and our efferent arteriole exiting. Now, what's a really interesting feature here is if you notice, we mentioned our proximal convoluted tubule coming straight off the capsule. There's also a distal convoluted tubule. Convoluted just means like squiggly or twisty. So if you notice that this part of the distal convoluted tubule here is right next to that Bowman's capsule, that's the cross section here. And essentially this is going to be how our renal corpuscle monitors like the salt levels, kind of that's, what's happening on further down, which is pretty cool. So right here, if we kind of zoom in, this is our afferent arteriole. So some of the cells in our afferent arteriole that are next to this cross section of the distal convoluted tubule, those have a special name called juxtaglomerular cells. Juxta just means next to, glomerular means glomerulus, right? So their cells kind of really close to our glomerulus, right? So juxtaglomerular or JG cells. And those are going to be within our afferent arteriole. They contain prorenin. So it's kind of just there and on standby. And essentially, when you activate these cells, it converts prorenin into renin. So that's part one, how we make renin. You have to activate these cells. How do you do that? Well, there's a couple different things. One, low blood pressure coming in is going to activate these cells to make renin. Two, low levels of sodium in chloride in our distal convoluted tubule. So it's kind of, we're monitoring essentially in this distal convoluted tubule, like, hey, how much salt is down there? So if the salt levels are low, it's going to activate these cells to make renin. And then part three, increased beta sympathetic flow through our beta 1 receptors. That just means that our sympathetic nervous system is also going to activate that, right? And so I know we said earlier that our parasympathetic nervous system is going to kind of promote, digestion, promote urination. Well, this is going to promote reabsorption of fluid, promote, reabsorption of salts and vasoconstriction, right? So our sympathetics is going to also influence our JG cells to produce renin. Okay, that's just 3 little areas. Now, what does renin actually do? And this is this section. So essentially, renin is going to convert angiotensinogen, which is made by the liver, into angiotensin 1. Angiotensin 1 doesn't really do anything, but essentially, angiotensin 1 is converted by a converting enzyme in the lungs, which pleasantly named is called angiotensin converting enzyme. It's gonna, formed, in the plasma membranes of the lungs pretty much. It's gonna convert angiotensin 1 to angiotensin 2. Now we have a whole bunch of stuff happening. So all of that was for renin to convert tensinogen to angiotensin 1, converting enzyme in the lungs, take angiotensin 1, convert it to angiotensin 2. So this is a pretty short or half-life compound, and essentially it's going to do a whole bunch of stuff. It's going to cause our blood vessels to vasoconstrict, so we increase our blood pressure. So that way we can get back to normal blood volume and blood pressure, essentially. It's also going to essentially go to our adrenal cortex here in our kidneys, on the top of our kidneys, which will produce aldosterone. see. And aldosterone essentially is going to cause our kidneys to take up more salt. So remember, a part of this whole system is to increase water reabsorption, increase our blood volume and blood pressure, and to increase our salt reabsorption, right? So aldosterone is going to do that, and that's converted or formed in the adrenal cortex. And then we also, angiotensin 2 also influences our thirst and salt appetite in the brain. It also increases, so essentially angiotensin 2 also increases our sympathetic outflow, which is going to kind of stimulate more renin, right, production. It's also going to cause our in our central nervous system to release vasopressin, which is from our hypothalamus. That's going to also be known as our antidiuretic hormone. And that's going to cause us to absorb more water from the kidneys, right? So if you've ever heard someone who's like on a diuretic causes, additional urination or excretion. So antidiuretic hormone, which you naturally produce in our hypothalamus, is going to do the opposite and cause our kidneys to absorb more water. So essentially, we've done it. The renin we produce is converted to, or converts angiotensinogen to angiotensin. That's going to be converted to angiotensin 2, which is going to do a bunch of things. It's going to cause our blood vessels to vasoconstrict. It's going to cause our adrenal cortex to produce aldosterone, which makes us absorb more sodium. It also is directly going to influence our kidneys to absorb more sodium. Then it also works at our thirst centers to make us thirsty, our hypothalamus to essentially produce antidiuretic hormone and reabsorb our water. So we have succeeded in increasing our vasoconstriction, our sodium and water reabsorption. Okay. All right. So this is just another way to see the same exact same thing happening. So if you like kind of maps that give you another way to look at things, maybe this is your style instead, right? So renin, angiotensinogen, forming angiotensin 1, going to the lungs to make angiotensin 2, which does a whole bunch of stuff, okay? So that's our renin, angiotensin, aldosterone, angiotensin system. Okay, so let's do another checkpoint. So what kind of stimulus is kind of cause these JG cells? Oops. Well, it already gives it away. Anyways, JG cells to release renin. So it's low sodium levels in DCT. It's sympathetic stimulation and then low blood levels in our afferent arterial. Okay. Now let's talk about electrolytes and how our kidneys help maintain the balance by what they're able to pull back in from our filtrate versus excrete. So when we think of electrolytes, you probably think of Gatorade. When you sweat a lot and you think, oh, I'm losing all my electrolytes, I better replenish them. You drink a Gatorade, right? So essentially, what are electrolytes? Essentially, they're just salts that dissolve in water to form electrically charged ions, right? So for example, NaCl is just table salt, right? And this is the molecular structure. We have sodium ions and chloride ions that are that bind together to form this kind of crystal-like structure called NaCl or table salt. Okay, so what's happening in these bonds? Well, essentially, sodium has one electrolyte or electron in its outermost shell, and chloride chlorine atom is missing one electron in its outermost shell. And because it's a single electron here, it's very easy to donate that to chlorine atom to essentially make it um, um, chloride, right? Ion, right? So this is called ionic bonding, where essentially one atom gives up one electron to the other, kind of donates an electron. And so why do we call, what's the difference between sodium versus Na plus? Well, essentially because, see this like lonely electron that we talked about in that outermost shell, because it donated that to the chloride atom or chlorine atom, uh, it becomes more positive because it's less negative than it used to be. So when we give up an electron, we become positive, and when we accept another electron, it becomes negative because essentially it's becoming more negative than it was, and this is becoming less negative, aka positive, right? So positive it means it lost an electron, negative means it gained an electron. Um, so what causes cells to dissociate? Well, water molecules are polar, which means that the hydrogen sides are typically kind of positively charged, and the oxygen side of the molecule is negatively charged. That's because the electrons of this molecule usually spend more time around oxygen than they do around hydrogen. So more electrons means negative, less electrons means positive. And because it has this polar structure, we have negative, positive, positive. Essentially, when you take salt and put in water, that negative charge on one side is going to attract those sodium ions, and the positive side of hydrogen is going to attract the negative part of the chloride ions, and it just causes them to separate. So it literally, water, the polarity of water causes NaCl to dissolve into sodium and chloride ions. Um, so we kind of give them special names when they dissociate. If it's positive, we call them cations. Negatively charged, we call them anions. The way I remember is like happy cat or like positive, and angry anions, it's negative. I don't know if that helps, but it helps me. So there you go. So why are electrolytes important? Electrolytes are incredibly important, and that because that's how we conduct electrical impulses for nerve signaling, muscle contraction, and cellular function. Water acts as the carrier for electrolytes. So essentially the fluids in our blood or in the extracellular fluid around between our cells, our electrolytes are kind of dissolved in water, right? So, how does this actually work? How do ions facilitate nerve impulses? Well, when you build up a positive side on one side of the cell, right, and a negative side on the other side of the cell, you're essentially creating an electrochemical gradient. So this is the cell membrane. It's going to create a barrier between the cell, like inside the cell and outside the cell, and it's going to use energy to pump sodium outside the cell. So if I have more sodium outside the cell, then the extracellular fluid or the fluid outside of the cell is going to be more positively charged than inside the cell. So we created a gradient or a difference between the charge. So it's pretty amazing, but these ions, these positively charged ions, you would think wouldn't do anything. But in fact, if you have enough sodium, they create a positive charge, just like a magnet, right? We have a positive charge, and then inside the cell, it's less positive, so therefore it's negative. So let's move on to talking about individual electrolytes and essentially, why they're important and what can happen if you don't have normal electrolyte level. So sodium, and up in this corner is going to be where normal values are. Okay. Sodium is found mostly outside of cells, right? So the cells are typically constantly pumping sodium out. We take sodium in through foods and fluids, and they're super important in creating electrical impulses, both within and across cells. Helps us regulate the amount of water in the body because essentially the kidney excretes sodium and water follows. So water is going to be pulled along with the direction of sodium, creating our urine. So hypernatremia, when we have abnormally high levels of sodium, what causes this? Well, it can be kidney disease if we're not able to process or filtrate appropriately, or if we have excessive water loss from diarrhea or vomiting or limited water intake. Basically, if you're very dehydrated, so that's one of the concerns with diarrhea and vomiting is that you're losing a lot of water, and therefore you're going to have a higher concentration of sodium. This can cause excessive thirst, tachycardia, anxiety, fatigue, altered mental status, and seizures. What about low levels of salt, hyponatremia? This can be caused by liver disease, some forms of kidney disease, congestive heart failure, burns, overhydration. So this isn't super common to have overhydration, but this is something to be aware of when, there's cases of, in the past, there's been water drinking competitions and hazing and things like that, where they think it's harmless and they're just forcing them to drink a whole bunch of water, and it actually depletes their sodium and it can be really dangerous. Another important thing to note is that babies under 6 months of age essentially should not be drinking water, but they should only be taking in formula or breast milk because their kidneys can't handle processing that much water. So hyponatremia is not as common, but can still be problematic. So what are some of the symptoms? Fatigue and nausea, vomiting, muscle spasms, weakness, and seizures. Now let's move on to potassium. So sodium we usually see outside of cells, potassium is usually inside of cells. It also works along with our sodium to generate those electrical signals in cells. Actions of our ion pumps and distal parts of our nephron in our collecting system are going to regulate potassium loss. So essentially here, right, our collecting duct, that's kind of what's going to be controlling how much potassium we reabsorb back into our bloodstream or we secrete into our urine. Okay. Perfect. So the collecting ducts is going to kind of titrate or control how much potassium we reabsorb versus excrete. And I wanted to show you back at this image we saw earlier. Remember the sodium that we pumped out, to create a positive charge? Well, when we do that pump, we also pump potassium in. So, and this essentially kind of dampens the polarization. So it's not as huge of a change when we pump sodium out and we will take potassium back in. We will still create a more positive charge outside the cell than inside the cell. Okay, so potassium is super important for creating that electrochemical gradient as well. And then this is just showing you that essentially sodium, when we have our action potential, right? Potassium is inside the cell, sodium is outside the cell, and we have our stimulus. Because there's a gradient, it's going to cause that action potential to, or the stimulus causes like kind of the ion channels to open, which will cause potassium to rush out, sodium to rush in, because there's that gradient between the outside of the cell and the inside of the cell. And there's also a higher concentration of potassium inside the cell. And so it's going to want to follow essentially its gradient with diffusion, right? And that's our action potential going down our axon. Okay. So now let's talk about what can go wrong. So hyperkalemia, this is high levels of potassium, can be caused again by renal disease. So if we can't control in our collecting ducts, the level of potassium being reabsorbed or secreted, as well as certain medications can also cause hyperkalemia. Some of the problems or symptoms that we see are muscle weakness, fatigue, numbness, tingling, nausea and vomiting, bradycardia, hypotension, respiratory arrest, and changes in our ECG um, exams, right? So hypokalemia, low levels of potassium can be caused by kidney disease, again, diarrhea and vomiting, because we can essentially lose electrolytes that way, or laxatives, sweating, diuretics. Um, and then this special category of medication, beta-2 agonists and antimicrobials or antibiotics. This can cause, again, weakness, fatigue, cramping, constipation, and ECG changes, right? Let's move on to chloride. So that's anion, right? Angry, negative anion. So it's a negatively charged ion found mostly outside the cell. We usually find it in our extracellular fluid or cell around fluid around the cells or outside of it. It's really important for our fluid levels and pH levels. And we typically absorb it, along our digestive tract with sodium and that NaCl or salt intake. It's also important in our nerve conduction and muscle cells. And it also is important for the flow of oxygen and carbon dioxide within our cells. So what happens if we have high levels or low levels? So high levels of chloride or hyperchloremia caused by severe diarrhea. So remember, diarrhea, we have to worry about fluid loss, but also electrolyte loss. Some kidney diseases and parathyroid gland diseases, they'll have symptoms of headaches, fatigue, nausea, tachypnea, hypotension, ventricular fibrillation, and then hypochloremia. So if we have low levels, it can be caused by excessive sweating and urination, vomiting, and issues with our adrenal glands. This can cause tetany, which is basically muscle spasms, weakness, difficulty breathing, and fever. Calcium is the most common cation. Remember, happy cat, so positively charged, found outside the cells. We have more calcium in the body than any other material, which makes sense because it's part of forming our bones and teeth. The extracellular matrix is made by calcium and phosphate. So essentially, it's super important as well in our extracellular matrix for conducting electrical signals and muscle contraction and blood clotting. So it is actually really vital ion, especially for muscle contraction. Homeostasis is maintained by our parathyroid hormone, calcitrol, which is going to basically pull calcium out of our our bones, and release it into our extracellular fluid. And then calcitonin, which is kind of the opposite, is going to reabsorb some of that free floating calcium back into our bones. Okay. So what happens if we have high levels of calcium? So hypercalcemia, it can be caused by tumors of the parathyroid glands, right? That are going to over secrete hormones, essentially pull more calcium out of our bones and have have kind of high levels of calcium in our blood. Certain medications, or if you overconsume calcium supplements, and they call the symptoms the moans, groans, stones, and bones. Moaning from kind of pain, abdominal pain, nausea, constipation, groans, it's lethargy, weakness, confusion, coma, stones. So if you have high levels of calcium, you're more likely to create kidney stones, have excessive urination and renal failure, and bones, you're going to have achy bones and pain there if you're going to be kind of essentially pulling more calcium out of your bones than is normal. Calcemia, so essentially like low levels of calcium. That's going to be caused by potentially chronic or acute renal failure. If you have deficiency in magnesium or vitamin D. Remember, vitamin D is activated by our kidneys, so we can absorb calcium from our gut. So if we can't absorb because we don't have activated vitamin D, we can have hypocalcemia. Hypoparathyroidism, so essentially like our parathyroids aren't active, pulling enough calcium from our stores, or pancreatitis acute can cause that. So if you have low levels of calcium, you can have confusion, lethargy, muscle cramping, weakness. Tetany is just like kind of contractures or cramping. Um, so like muscle contractures, right? Paresthesia, Trousseau's sign, Chove-Steck sign, congestive heart failure, EKG changes, cardiomyopathy, and seizures. So essentially, this Trousseau sign happens when if someone has hypocalcemia and you put a blood pressure cuff on them and you pump it up, they're going to have this sign where they have essentially flexed metacarpals and extended fingers and opposition of the fingers. Opposition of the thumb, right? So that's kind of a sign there that we can see. Chove-Steck sign is essentially if we have the facial nerve that's right around here where that parietal gland is, or parotid gland. We'll find that facial nerve. Facial nerve innervates muscles of facial expression. So what happens is someone's poking that or tapping on that nerve, and it's going to have kind of abnormal muscle contraction of the muscles of facial expression. Now, if our plasma calcium levels drop, so below 50% normal, which is like below 9.4, so if they just drop below 50% of our normal rate, then you can potentially have spontaneous action potentials, which can cause contractions of our peripheral skeletal muscle system. So if your calcium levels go exceedingly low, you can have spontaneous contractures, which is not great. Okay, so moving on to phosphate. So phosphate, if you notice, it's actually a molecule here that's bound with oxygen. So phosphorus is the atom that's bound with oxygen, and essentially it's kind of collected, four oxygen. So it's one phosphorus to four oxygen, and it has three additional electrons. So it's that's why it has the -3. Okay, so phosphate is really important. Phosphorus is the second most abundant mineral in the body, second to calcium. We also find it in our bones. So our calcium and phosphorus are really important for extracellular matrix, forming kind of the supportive structure of our bones. It also is important for intracellular fluid because it activates enzymes so we can synthesize nucleic acids. We reabsorb it from our tubular fluid in our nephron, stimulated from that calcitrol. So calcitrol is causing us to reabsorb our phosphate ions here, right? It's also super important for ATP production, and ATP is important for our energy source for our cells, and we need that to repair and reproduce our cells, aka like grow and fix, right? So that's our bone, right? That's where we're going to have our kind of largest storehouse for calcium and phosphate or phosphorus. So phosphorus is like essentially the atom, and then as an ion, it's bound with the oxygen, with the four oxygen molecules or atoms. So when we have high levels of phosphate, right? Hyperphosphatemia is caused by kidney disease or kidney failure, or if we intake too much phosphate, hypoparathyroidism, or metabolic or respiratory acidosis. It's going to be similar to our hypocalcemia. And then hypophosphatemia, that's going to be caused by essentially our parathyroidism that's preventing our kidneys from um, reabsorbing the phosphate levels, or from poor diet, diabetic ketoacidosis, or respiratory alkalosis. What's that going to cause? Weakness, bone pain, rhabdomyolysis, altered mental status. And here's our blast ion is magnesium, fourth most abundant, typically found inside cells. It's really important for our nervous system, muscle contraction, cardiac physiology. It's a cofactor, so it's important for around 300 and more enzymes that help regulate biochemical reactions, including protein synthesis and several other functions, right? Really important for DNA and RNA synthesis and bone formation. So magnesium has a lot of important features. What happens if we have too much or hypermagnesemia? It's usually caused by kidney disease. So if we see a theme here, because our kidneys are unable to, um, um, you know, work properly to create this balance. Kidneys aren't working, then we end up with hypermagnesemia. We can also have over intake of magnesium, lithium intake or lithium therapy, hypothyroidism or Addison's disease. It's caused lethargy. We kind of dampen our tendon reflexes. We can have nausea and vomiting, skin flushing, respiratory depression, failure arrest, hypotension, cardiac arrest, and then low levels of magnesium can be caused by alcoholism, diarrhea, burns, polyuria, hypercalcemia, and it can cause weakness, tremors, tetany, paresthesia, heart palpitations. So if we just notice that a lot of these electrolyte imbalance is really important, they can have some severe symptoms, right? So let's talk about acids and bases, because this is gonna essentially determine our pH level in our blood, which is a very small scale. So our acids are electrolytes that release hydrogen ions in water, and bases, which is we also consider alkaline, are electrolytes that are going to release hydroxide ions that bond with hydrogen, right? So if you notice, if you just took water and you separated 1H, you're going to end up with your acid, right? Your hydrogen ion, right? And then with your hydroxide ion as well. So essentially, the amount of hydrogen ions that are just kind of in that plasma or that fluid is going to determine our pH level. So pH is just a scale. 7 is neutral, and then as we go smaller, it becomes more acidic. As we increase the number, it becomes more alkaline or basic. So bicarbonate is essentially a really important buffer that we produce, and it's considered alkaline, so it can bind with those hydrogen ions and kind of pull those out of our blood system. It's excreted and also reabsorbed by our kidneys. So if there's bicarbonate in our filtrate, the kidneys can reabsorb that to increase our buffer level. It's really important for regulating our pH or acid balance, and it also works with sodium, potassium, and chloride. Again, how is it? It's important for our buffer system. Well, essentially, about 3/4 of our carbon dioxide is converted to carbonic acid, and then that's turned into bicarbonate. So kind of show you this formula. So essentially, water and carbon dioxide is going to cause the carbon dioxide to dissolve in the water and form carbonic acid. And if carbonic acid gives up one of its hydrogens, it forms our bicarbonate. And that's going to kind of give us an endless amount of buffer that can help us control our pH, right? Okay. So just wanted to go back to this slide again, that tubular reabsorption is key for reclaiming our water and maintaining our electrolyte balance. So reabsorbing from the filtrate, now we know what some of this stuff is, right? Our salts, potassium, water, glucose that we cared about, and our bicarbonate, right? We're going to reabsorb that. Magnesium and calcium. And then kind of along the way, it's still pulling out more um, of our electrolytes from the filtrate back into our bloodstream. Okay. So I know that was kind of a lot, and here's some kind of a summary to share like what's the most important when it comes to electrolytes. Hyperkalemia, so high levels of potassium is the most important to be aware of, right? So people, with kidney disease or need dialysis are at the highest risk. So you should be aware if someone is having an electrolyte disorder or imbalance, if they've had a lot of nausea, vomiting, and or diarrhea, um, if there's kidney disease, we have to worry about their electrolyte balance, right? If they start having unexplained weakness, muscle spasms, numbing, or tingling, we also have to look at electrolyte disturbance, right? Um, it might also cause patients to have altered mental status or reduced level of consciousness. So those are kind of the most important takeaways from um, this section on electrolytes. Let's do a checkpoint. So after we placed a blood pressure cuff, we noticed this sign. So what is the presentation we're observing? So that's Trousseau sign. Okay. And then this sign is what caused by what? Electrolyte imbalance. Hypocalcemia. Okay. So that's something to kind of be aware of, right? Now let's talk about pH. So how does our body respond to changes in our pH? So we introduced acid and base, and we talked about acids being electrolytes that are going to release hydrogen ions, bases release hydroxide ions, and that's going to determine our pH scale. We talked about our buffer system, essentially water and carbon dioxide dissolve, I should say carbon dioxide dissolves in water to form carbonic acid. That typically will right away give away one of its hydrogen ions and form our buffer system. And the buffer can kind of, balance and, pull bind back with that hydrogen ion to change the pH, right? So normal blood pH is 7.4. Acidosis is less than 7.35, and alkalosis is greater than 7.45. So it's a very small range that or very tight range that we want to keep our blood pH in. So how do we kind of control our pH? Again, you might hate pictures like this, but we'll go through it one by one. Let's talk about this chemical buffering in our extracellular fluid. Bicarbonate that is going to help neutralize acids, and then carbonic acid, right? So we're going to have some carbonic acid from dissolved CO2, right, in water. Carbonic acid can help neutralize our bases. So that's at the like blood plasma level or extracellular fluid level. Then if we talk about our lungs, it's actually, expiration or breathing out is going to be a huge part of balancing our pH level in our blood, right? So carbon dioxide in our blood, which we produce from our cells, it's literally a waste product, is going to be taken up by our red blood cells and converted to carbonic acid and then to bicarbonate. Bicarbonate is taken to our lungs, converted back into CO2, and we exhale it. So that's how we get rid of CO2. So if we have, if we need to get rid of like a lot of carbon dioxide, or um, if we are, more acidic than, or if our blood plasma level is too acidic, sometimes our body will cause us to hyperventilate and try to breathe off more carbon dioxide. Okay. Now, lastly, this next layer is our kidney. Our kidney can influence our pH by reabsorbing bicarbonate from filtrate, and then also getting rid of literally straight up hydrogen ions. So our kidney has a way of excreting hydrogen ions, um, which are going to have urinary buffers that it joins with, and then we urinate that out. So our kidneys can just straight up get rid of hydrogen ions for us and reabsorb more buffer, which is nice. So what are some kidney disorders we can see? There's pyelonephritis, and when you see this, itis or something like that, you can think of inflammation or infection. So this infection can cause, that impacts the pelvis, medulla, and cortex. It can be really problematic and require IV antibiotics and even hospitalization. So treatment with antibiotics. There's also diabetes insipidus, and you might think it's related to diabetes mellitus, but it is very much not. It's a completely different disorder, and it's noted by essentially producing a large quantity of urine and having like excessive thirst. Okay, and this is caused typically by decreasing our production of our antidiuretic hormone. Remember, that's produced by our hypothalamus. So excessive thirst. How do we treat this? Give them fluids, low sodium diet, because that's going to, essentially exacerbate the situation. Also, see if the medications they're taking that's causing diabetes insipidus. And there are medications to treat it as well. Different causes, different types that can cause diabetes insipidus is called central DI. So essentially, your hypothalamus is not able to cause production of vasopressin or antidiuretic hormone, which can be caused, basically we don't know, or tumors, surgery can cause that, trauma can cause that. Nephrogenic, aka we make vasopressin, but our kidneys aren't responding to it. Dipsogenic, basically we're drinking way too much fluid, because our thirst mechanism is not functioning and is making us essentially excessively thirsty and drink an excessive amount of fluids, and so you're having an extreme amount of urination. And gestation, DI, which means that people who are pregnant may have excessive vasopressinase, which will kind of impede with our vasopressin, and so you'll have like kind of increased levels